Now, okay. Great. So welcome, good morning, good afternoon, everyone. So my name's Dr. Manish Sadarangani. I'm a pediatric infectious disease physician scientist at the University of British Columbia and BC Children's Hospital. And I'm here in my role as chair of CAIRE, which is the Canadian Association for Immunization, Research, Evaluation and Education. And we are co-hosting this particular webinar with CVPD, the Centre for Vaccine Preventable Diseases, based out of the University of Toronto and the Dalla School of Public Health. So I'm delighted to have two excellent speakers and to see so many people here today. And today we're going to be talking about building an off-the-shelf system for vaccine safety to address emerging issues. And we've got Steve Black and Julie Bettinger who are presenting. I just want to start off with a land acknowledgement before we start. So the CAIRE administrative offices are based at BC Children's Hospital Research Institute, which is where I am based, and we operate on the traditional, ancestral and unceded territory of the Coast Salish peoples, which includes the Musqueam, Squamish and Tsleil-Waututh nations. And in addition, I want to acknowledge the University of Toronto lands, and for thousands of years, this has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting is still home to many Indigenous people from across Turtle Island, and we're just all very grateful to have the opportunity to work here and live here. And for those of you joining from elsewhere, I invite you to take a moment to just reflect and acknowledge the land where you live and where you work. Just some brief housekeeping things. So what we're going to do is we're going to have the two speakers, and then we'll do all the Q&A at the end, and we'll try and get through as many questions as we can. If you have any questions, please use the Q&A function of Zoom. And if you have any questions afterwards, you can send anything to the CVPD email, which has been put into the Zoom chat there for you. We do have closed captioning in English available during the webinar, and instructions on how to view the closed captions have just been popped into the chat. And please bear in mind, this is an automated service, and so if there's any transcription errors, then please be tolerant of those. So without further ado, I'm going to introduce the two speakers today. So Dr. Julie Bettinger, so she's a professor at the Vaccine Evaluation Center in the Department of Pediatrics at the University of British Columbia. She's an infectious disease epidemiologist whose research interests include vaccine safety and vaccine preventable diseases, as well as attitudes and beliefs around immunization uptake and use. She's the data center director for the Canadian Immunization Monitoring Program Active, which is an active surveillance network across Canada monitoring vaccine preventable diseases and vaccine adverse events in pediatric hospitals. She's also the principal investigator of the Canadian Immunization Research Network's Canadian National Vaccine Safety Network, otherwise known as CANVAS, and this monitors the safety of influenza vaccines each year and has been monitoring COVID vaccine safety over the course of the pandemic. Our second speaker today will be Dr. Steve Black, and he's a pediatric infectious disease specialist who received his degrees in biology and chemistry from the University of California, Santa Barbara, and an MD degree from the University of California, San Diego, and then had a fellowship in University of California, San Francisco. And he spent over 30 years conducting clinical trials and safety studies of vaccines, including being the PI in 5 pivotal licensure trials and 6 phase 4 post-marketing trials. And he's also been involved and led numerous phase 1 and 2 trials. He is now co-director of the 25-country Global Vaccine Data Network and currently engaged in the safety evaluation of COVID and other vaccines. And he leads DSMB activities for the CEPI-funded SPEAK project supporting the assessment of vaccine safety in CEPI-funded clinical trials. And he's currently Emeritus Professor of Pediatrics at the University of Cincinnati Children's Hospital in Ohio in the US, and Honorary Professor of Pediatrics at the University of Auckland in New Zealand, as well as the Editor-in-Chief of the Pediatric Infectious Disease Journal. Finally, before we get into the speakers, I just want to introduce Jeff Kwong, who will be moderating the Q&A session afterwards. And Dr. Kwong is the Associate Director of the Center for Vaccine Preventable Diseases and the Program Leader of the Populations and Public Health Research Program at ISIS, as well as Professor at the Department of Family and Community Medicine and the Dalla School of Public Health at the University of Toronto. So I believe, Dr. Bettinger, you will be speaking first, so I will hand it over to you and really look forward to hearing both of your talks. And thank you again for agreeing to do this webinar for us.
Great, thanks, Manish, for the lovely introduction. Whoops, I think I just took my slides out. Let me just, there we go. So I'm delighted to be here today to talk to you about vaccine safety. And in particular, I'm going to be focusing on the Canvas COVID vaccine safety surveillance that we initiated to look at the safety of COVID vaccines in Canada. So my slides are not moving forward. Okay, maybe it's just slow. So I don't have anything to disclose, just to start off with that. And I think we have a fairly diverse group who may be listening in today, I thought it helpful to sort of start out with a definition of what we mean when we talk about vaccine safety monitoring. And so this is really the detection, assessment, understanding, and communication of what we call APHEs, or adverse events following immunization. And this looks at both the prevention of the unintended effects of a vaccine or of the vaccination process itself. And this is something that is really essential, because when we think about using vaccines, unlike maybe other medical devices or medications or medical treatments, we're giving vaccines most often to a healthy population. And therefore, understanding the risks and benefits of the vaccine is a slightly different risk-benefit equation than when we look at maybe someone who's ill and the treatment is the only thing that may save their lives. So it's really critical that we have this sort of monitoring in place, and it's critical that we have it through all stages of the vaccine process. And I think oftentimes what people don't appreciate is that, in fact, we have a very rigorous safety process that starts before we even ever give a vaccine to an individual. First, we look in preclinical studies at the safety of the vaccine in animal models. If it's shown to be safe in that setting, it then will move into human studies with a phase 1 clinical trial. And these are generally very small trials with about 30 to 50 vaccinees, and it's looking for really common adverse events, sort of just establishing that it's safe. If the vaccine looks good in a phase 1 trial, it moves on to phase 2 trials, and these are slightly larger trials, sometimes up to a sample size of about 100 participants. And at this point, we're able to sometimes predict an event rate of about 1 in 1,000 in terms of an occurrence. So slightly less frequent adverse events we would be able to pick up in a phase 2 trial. When we get to phase 3 trials, these are the larger studies, and these are also at this point looking at the efficacy of the vaccine, so whether or not it actually works. And these can range from 1,000 participants to tens of thousands of participants. The rotavirus vaccine trials that we had prior to the licensing of that vaccine had 60 to 70,000 infants enrolled. So these trials can get quite large. And in this setting, we're really able to start picking up some more rare adverse events. But it doesn't stop there. With the vaccine approval, we do have safety that continues on in the post-marketing phase, or the phase 4 phase. And this is really the first point that we can really start noticing things that may occur in 1 in a million, because this is when the vaccine's used at a population level, and we finally have a sample size, if you will, large enough to be able to really detect these very rare, very unusual adverse events. And so there are several ways that you can sort of look at vaccine safety. I'm going to talk about 2 of the most common. There are other ways, and Dr. Kwan is involved with a lot of this work in terms of administrative data analysis. But what I'm going to focus on today are both passive surveillance and active surveillance. And passive surveillance, as the name implies, relies on spontaneous reporting. You're not looking for things, you're just waiting for the events to be reported into you. This is primarily for signal detection, and it can detect unexpected events, because you're just kind of sitting there waiting for people to tell you about things. In Canada, the passive surveillance relies on reports from healthcare providers. Because it is passive, we do have very inconsistent data quality with this, and it does result in quite a bit of reporting bias. So it's great for sort of covering the whole population, for finding really rare events, but we sort of have to keep in mind its limitations, and that we're not really capturing everything that may be out there. So then in that sense, or because of its limitations, we also have more active surveillance that we can use. use. And this is really a system where you often will define a set population or a set geographic area, and you will capture all of the adverse events in this population area or in this population. And the impact surveillance that I'm involved with that was mentioned up at the top during my introduction is a type of active surveillance. And this again is for signal detection, but with this type of surveillance, you can also evaluate sometimes the causation, or at least look into that in a bit more detail. It's hard, depending on how this is set up, it can be difficult to detect unexpected or rare events, but you can also set it up in ways that would make this easier to do. Its strengths are that it has much more systematic data collection, it can be more timely, and it is more representative if it's set up correctly. The real limitation with active surveillance, as you can probably guess, is it's much more resource intensive than what we do for passive surveillance. So another system, that I'm involved with and that you'll hear about, so the way, actually, let me back up here. The way that these two work together is to sort of have our passive and our active systems in place and feeding into the Canadian Adverse Event Following Immunization Surveillance System. And so this system is set up across Canada in all of the provinces and territories, primarily passive surveillance at the PT level, but Impact does feed its reports into here. And so that's where the active component comes in. But it is only for pediatric hospitalizations that go into this. So adults, events occurring in adults are not fed in through an active mechanism. And then the other one I'm going to talk about, which is slightly different from what I've already mentioned, is the Canadian National Vaccine Safety Network, or CANVAS. And this is slightly different from either the passive or the active in that it's more of an active participant-based reporting of APHIS. And it started off initially looking at influenza vaccination, but with the advent of COVID vaccines, we pivoted the network to also collect safety information on COVID. And what's slightly different about this than the other reporting systems we have in Canada is that the reports are actually coming from the vaccinated individual themselves. And we also have an unvaccinated control group that we include. So our CANVAS COVID surveillance currently has over 1 million participants enrolled in BC, Yukon, Alberta, Quebec, Ontario, Nova Scotia, and PEI. We're collecting information on the age group of the person vaccinated, the type of vaccine they got, their underlying health status, and whether or not they've had a previous COVID infection. We also collect information on whether or not they're pregnant or breastfeeding. And then the way it has been set up for CANVAS COVID is that we've got an online survey that goes out 8 days after the first dose of vaccine, 8 days after the second dose of vaccine, and then a final survey that goes out approximately 7 months after that first dose. And so we're able to capture sort of that immediate week after vaccination, and then also that time period in between the dose 1 and dose 2, and then the longer term follow-up for any sort of emergency department visits or hospitalizations that occurred out to 7 months. So what we're primarily looking for in those first dose 1 and dose 2 surveys are what we have termed severe health events. So these would be events that would cause work or school absenteeism. So they're severe enough that someone would stay home from work. It would prevent their daily activities, or it would require a medical visit. And then within the medical visits category, we look at what we would term more serious types of medical visits. So emergency department visits or hospitalizations. And then, as I mentioned, we do have a control survey of unvaccinated controls that captures their health events over a 7-day period. And this is really unique compared to a lot of other safety systems. And it really enables us to sort of then be able to establish what a background rate of, say, fever looks like in someone who hasn't been vaccinated, and compare that to what our rate of fever is looking like in individuals who have been vaccinated. So for both of our groups, the unvaccinated group and the vaccinated group, for anybody who reports a medically attended event, we do a telephone follow-up to just sort of establish more information about what that event was, and if possible, try to, if they've got a diagnosis from that event, we capture that as well. Okay, so throughout CANVAS COVID, we've been very active in sort of doing real-time reporting to public health at both a provincial and federal level. And so I've got a screenshot here of sort of our weekly summary report that's gone out on a weekly basis, providing more detailed information on each of the vaccine products. And this through this, we've also monitored a variety of signals throughout the campaign. We've looked at the changes in menstruation that was, I think, first sort of started popping up in our data in about February to March of 2021. We looked at some visual disturbance or visual problems as another signal. Shingles was a question that came up early in the campaign, and we took a look at that in our data. Myocarditis, pericarditis, and paresthesia. These were all things that we were able to sort of do a more detailed analysis of what we were seeing in our data, as well as what we were seeing in the control group. And so a lot of these analyses were done on the preliminary data as it was coming in and shared with public health. They're not out in the peer-reviewed literature yet. We may be working on trying to get some of these out, but really the point, at least throughout the campaign, was more real-time monitoring and less about getting the results out in peer-reviewed journals. So, that said, one of the goals of this as a research program is we are planning to do some additional summaries. And so we will be looking at safety of COVID vaccines in adults overall with a very detailed summary coming out. We've already put out a publication, which I'll show the results from in the subsequent slides, on the safety of our mRNA vaccines in pregnant people. And we're also working on one in children. And I'll give you a sense of some of that today, although some of these results are still ongoing. So in addition, we on a weekly basis have been updating our website for participants or really anybody else who's interested in a very high level summary of what we're seeing in the data. And so this screenshot here is taken from the website. You can just see the events in adults here. These are the events that have been most frequently reported in adults, and you can see flu-like symptoms, headache or migraine, nausea, vomiting, and diarrhea, and the proportion of participants who have reported experiencing these symptoms after each dose. When we look at events in kids, again, I think what's notable is we've got about almost 250,000 kids after dose 1 and about 130 after dose 2 so far. And you can see that the vast majority, so 94 and 95% after each dose, have reported no health events. So they've been vaccinated without an issue. When we then look at, okay, well, what was actually reported, an even smaller proportion, so 4% and 3% after each of the doses, had an event that was severe enough to prevent their daily activities or require medical care. And what did those events look like? So in that group, you can see, again, very similar to the same types of events that we're seeing in adults. So flu-like symptoms, headache or migraine, nausea, vomiting, and then fever was also frequently reported in kids. Now I've got the proportions here on the slide. So I'll spend a little bit of time going through our pregnancy data, because I think, again, the COVID vaccines have been recommended for pregnant women. And in the initial preclinical studies, pregnant people were not included in those studies. So we didn't have a great deal of evidence, at least as the vaccines were initially rolling out. And so I think it's really important to sort of look at the evidence we do have now. And what you can see from here is we've got our pregnant vaccinated group. We have a non-pregnant vaccinated group. So this would be a group of females. And then we have our pregnant unvaccinated control group. And so just looking at health events after each of the doses of vaccine in our 2 vaccinated group and just health events in the unvaccinated group, you can see that the rates in the pregnant and the non-pregnant group who received the mRNA vaccines are quite similar. You can see for both of the vaccinated groups, the rates are slightly higher than what we see in our control group. I think, though, what everybody is most interested in when we talk about pregnant people are more events that would lead to miscarriage or other pregnancy complications. And so we've listed what was reported into the network here in this slide, and you can see there's very little difference in the vaccinated and the unvaccinated pregnant groups, with maybe miscarriage being slightly higher in the unvaccinated group. So what's getting reported in, though, in the individuals who are reporting symptoms? And these would be, again, the severe symptoms that prevent their daily activities or led to a medical visit. So again, similar to what we saw in the adult and also the kids groups, fatigue, muscle ache, feeling unwell, sort of these flu-like symptoms, and headache and migraine are the most commonly reported events. What you can see though from the proportions here when we look at pregnant people who were vaccinated compared to pregnant people who were not vaccinated is you're seeing a higher rate of these events occurring in our vaccinated group. But when we sort of look at this in terms of a rate ratio and adjusting this for their age group, their trimester of pregnancy, and whether or not they've had a previous COVID infection. And again, this is comparing our vaccinated pregnant people with our unvaccinated pregnant people. What you see from these, and the slide on the left here would be any severe health event. And the slide on the right here would be the more serious medical events, so an emergency department visit or a hospitalization. And I think what's reassuring, and maybe I'll just walk people through this, the dotted line is 1. And so if we've got the lines crossing 1, there's no significant difference between our vaccinated and our unvaccinated groups. And so I think, you know, what's reassuring in looking down this is you can see there's no significant difference in terms of our ED visits or hospitalizations after any mRNA vaccine or after either the Pfizer or the Moderna vaccine. We also don't see any difference in events occurring after dose 1, as you can see from here. Where we start to see a difference, and this is the only thing where there was a significant difference, is in this dose 2, and it's really related to seeing more events occurring in people who receive the Moderna vaccine. So that's sort of fever, the unwell, the nausea, vomiting, and diarrhea, headaches, more likely to occur in pregnant people who had the Moderna vaccine and more likely to occur after their second dose. So what about when we're looking at pregnant people, vaccinated pregnant people, as well as unpregnant vaccinated females? So again, these would be our 2 vaccinated groups. And I think what we can see from this is that there are no difference in health events occurring, and there's no difference in emergency department visits or hospitalizations for the Pfizer vaccine here. However, what is interesting is that we do see that in that Moderna group, and remember from the previous slide, this is the group that did have more events occurring after that second dose. For that group who had those events, they were more likely to seek care for these events in the emergency department or hospitalization. So we're sort of seeing a higher level of concern, and it's impacting sort of their health-seeking behaviors. So I think what we conclude from the data so far is that the COVID vaccine is well tolerated in adults and children. We've sort of shown that mRNA vaccines are safe in pregnancy, and hopefully this will allay some fears that some people might have about getting vaccinated at that time in their life. And I think finally, what Canvas really shows is that it's possible to do very rapid safety monitoring in vaccinated individuals, and it allows us to have some real-time signals that we can then investigate further as the mass vaccine programs are rolling out. And so I would just like to acknowledge the study team involved with this. Clearly, with a study this size, you don't do it alone, and there's no way that we could have done this work without the contributions of everybody involved here. And I also want to just thank our provincial and territorial collaborators, because again, this type of work doesn't happen without a really large team with a lot of support. So thanks, and I will hand over from here.
Hi, so thank you, Julie. I think that was very impressive. I hope you can hear me. I'm now going to talk to you about another effort of which several Canadian sites are involved in, actually, and I'll show some of that information. But what I'm going to talk to you about is the global collaboration to assess vaccine safety, the global vaccine data network. So what is an overview of what I'll present? I'm going to talk to you about the genesis of the GVDN, our work model, what the current status is, and some next steps that we're thinking about. So the GVDN really began after the 2009 influenza pandemic, if you can remember back that far. There was a possible risk of narcolepsy that was identified following vaccination in Finland. And the subsequent response to that globally was not coordinated. different countries found different levels of risk. 16-fold increased risk in Finland, no increased risk in the Netherlands. And it took 6 years before the US CDC funded study, the Somnia study, sort of untangled this story. So to be sure that we can be more timely and this not happen again, Helen Petousis-Harris and I organized a meeting of the GVDN in Annecy in France, shortly thereafter. And it's been supported. The GVDN was initially supported by the University of Auckland until CDC funding became available after COVID, and we'll talk about that more in a minute. So the problems that the GVDN is addressing are, one, rare events, as Julie pointed out, require very large populations to assess them, and multi-country collaborations can facilitate that. Single country studies often have very limited variability of vaccine schedules and agents, so that if you want to compare different vaccines, you need more than one player. However, lack of stable infrastructure has limited coordinated responses in the past, and we're hopefully past that point. So the GVDN is a network of sites agreeing to conduct globally coordinated active surveillance and epidemiologic vaccine studies. So by doing this, as I said, we have increased statistical power. The GVDN is multinational, and importantly, it's investigator led, as I'll show you in terms of how the studies have developed. And in 2021, we commenced activities on assessing the safety of COVID-19 vaccines. So this is sort of a broad overview of the GVDN sites and populations. We don't have anyone in Antarctica, but we do have representation in 6 continents with very active participation from Canada. There are 25 countries overall with 29 sites, as several countries have multiple sites. And the population is above 250,000. The model is that their site leads and their teams, their partner sites, and the Global Coordinating Center, which is in Auckland, oversees this whole collection in the network by doing contracts management, legal, finance, statistical support, research platforms, focusing mostly on REDCap, and management and coordination of international conference calls, etc. So the GCOVS project, as we call it, which is assessing COVID vaccines, was funded, as I said, in 21. And while billions of doses of vaccines have been given globally, I think we all need to recognize that post-introduction safety data is very limited, except for Pfizer, AstraZeneca, and Moderna vaccines. In many countries, other vaccines manufactured in China or the Soviet Union or in India have not been evaluated. And I'll mention to you in a bit, the collaboration has recently expanded to include collaboration with the ALIVE network of low-income countries in Africa. An important component is genomic studies are being undertaken to offer the promise of being able to identify genetic risk factors for adverse events such as myocarditis, and also potentially to understand mechanistically what's going on there. And the other effort that's looking at this outside the GVDN is the INSIS project, which is a Canadian-led effort. So these are the work packages and leads. You can see there are a lot of activities. Some of them are sort of generic, such as rapid cycle analysis or observed versus expected counts. Others are outcome specific, such as myocarditis, VITT, GBS, vaccine-mediated enhanced disease. And importantly, there's also a maternal immunization module, which is looking at this in several aspects. And there's a vaccine confidence group. Recently, and I'll talk about this a little bit, we've expanded our effort to look at smallpox vaccination when it's used for monkeypox prevention. What I want to highlight, as you can see on the right, these are being led by multiple different countries. New Zealand is leading a couple, but others are being led by different participants. So the current status is that background rates have been collected and are awaiting site review before they're being displayed on the GVDN website. Observers' expected counts are a few weeks behind that, and they'll be on the dashboard when the data cleaning and checking is complete and sites have approved them. The protocols for association studies for myocarditis, pericarditis, Guillain-Barré, vaccine-induced thrombotic thrombocytopenia have been developed by the working groups, and sites are collecting data now, and we're trying to work on logistics for chart review. Protocols for maternal immunization and vaccine-mediated enhanced disease are nearly final and will be sent to the sites to implement after they're reviewed and commented on by the sites. And specimens for assessment of genetic risk factors are currently actively being collected for the 3 outcomes that are shown. So this is an example of what GBS rates look like from ISIS. You can see here there's an overall rate, and the band is the 95% confidence interval, and these are available for all countries that have provided data. And there's several ways of looking at this that are user selectable. Here's another one showing this broken down by sex for generalized seizures from France. So there are 4 core association studies. Vaccine-mediated enhanced disease is something that is very complicated to assess, but we're working on that. And importantly, for maternal immunization, there are 2 ways we're looking at it. One is a retrospective pregnancy cohort, and also within each of the outcome studies for myocarditis, for example, or GBS, there's a pregnant women will be participate in a nested study in each of those. For smallpox, we're basically adding on all of the activities that I showed you, except for vaccine-mediated enhanced disease. The effort, I think, is we've now determined is being hindered because in many countries, data on exposure is being closely guarded to protect the privacy of the individuals, and in many countries is not in vaccine registries, which may protect privacy, but makes vaccine safety assessment difficult to impossible in those countries. To mention, there's also communication of vaccine confidence. We have a newsletter, which if you're interested in, you can look up the GVDN website, and we'd be happy to send you an issue. This is the website here. I want to spend a couple minutes talking about the Alive GVDN collaboration because it has important implications for vaccines that will be introduced into the third world in the future, such as Lassa, Ebola, most actively right now, MERS, etc. So the Alive project, Alive is an existing network of 8 countries in Africa. As you can see on the map on the right, the GVDN is a technical partner for this. We're supporting database development for a pilot in South Africa, and also database support for the 8-country network. And all of these countries are active GVDN participants now, and we'll be feeding data into existing GVDN protocol. So these are the countries, the site within the country, and the site leads for these countries. Some of them are very experienced clinical trialists. Others are relatively new at this, but all of them are working actively now to collect data. And the way this is done So you can see is that they screen all emissions manually. This is done by a person. If there's a possible case of ASI, a red cap form that has been developed for each of the ASIs under surveillance, data is collected for that, and the internal logic will automatically classify the cases using a Brighton collaboration case definition as to whether it's a confirmed case or not, and also assign a level of certainty. And then de-identify data on those cases, along with vaccine exposure information, is entered into a database, a central database in South Africa. So a combined analysis will be done in South Africa, and a meta-analysis, including these data with other GVDN sites, will also be done. So the future goals is to expand participation. Our initial focus is on Asia and South Asia and the Pacific, where we're underrepresented. We also are interested in extending the LMIC model beyond India and South Africa and the Alive network to other countries. And also we're interested in evaluating how to encourage a transition to electronic health record at selected sites to allow more rapid response. We are also beginning to think about AI models that will allow us to obviate the need for chart review in selected cases by looking at data that's available in databases. And importantly, to do any of this, we need a sustainable funding model. A step in this direction is new funding we just received from CDC to extend the scope of the project for another 2 years. So thank you. I appreciate your attention.
Oops. Thanks, Steve. That was great. Thanks, Julie, for your great presentation. So, just a reminder to folks that if you have any questions, you can use the chat function because there's no Q&A function for this today's session right now. So you can just type your questions into the chat, and I will be asking the questions. Just to get us started, I've got a couple of questions. So first, for Julie, Canvas seems to be like a really unique platform to Canada, and especially, with the inclusion of a control group of unvaccinated individuals. Why do you think this hasn't been replicated in any other countries yet?
Yeah, thanks. Great question. So I think it has, or at least parts of it have been replicated in other countries. So the US put in a system, I think it was primarily via their healthcare workers who were first vaccinated, looking at the vaccinated healthcare workers with COVID vaccines. So they rolled that out with the COVID vaccines. And then Australia has had a system in place for a number of years, again, primarily though just including kind of vaccinated individuals. And so I think there's some challenges with trying to include an unvaccinated control group and trying to make sure that that unvaccinated control group is similar enough to your vaccinated group that you can make valid comparisons. So I think that's one reason perhaps why this hasn't been included in more places, but it's not impossible. Obviously, I mean we've got it in place, and what we do for COVID, it was a bit easier because of the staggered rollout of the vaccines. We were really able to kind of enroll people and capture their responses before they got vaccinated, and we always have a little bit of a that gives you. Depending on how the rollout kind of works, you may be a little bit off in terms of the time response, like your control response may be slightly before the people who are vaccinated. So that's a limitation of it, but it still gives you a sense of what's happening in terms of background rates, which I think can be really helpful, particularly with some of the symptoms that we collect, and then really trying to figure out, well, is something occurring at a higher rate than what we're seeing in people who haven't been vaccinated? I mean, that's really the point. It's not establishing causation. We can't say with any of our data that the vaccine caused this. It's really just an indication of, oh, we may be seeing something. So maybe we need to do another type of study like the studies that Dr. Black mentioned, and looking at these administrative databases to see if there's really something there and quantifying it a little bit better. So I'll stop there and let other questions come in.
Great, thanks, Julie. Here's a question for Steve. So, I mean, what you described, with GVDN is pretty incredible. But what do you think has been the biggest challenge to date in setting it up?
Well, I think there are many. I think one of the most frustrating things is that, as I mentioned, we initially conceived of this 10 years before COVID came around, but there was really no funding, no interested funders. So that by the time we actually got funding, we were well into the pandemic and vaccines were already being used. So we were scrambling and still are scrambling. We're behind in terms of collecting data. So I think that's probably the main challenge is identifying sustainable funding so that when there is another outbreak of something, which I think we all recognize is likely to occur, that the infrastructure is there, the contracts are in place, the connections are there, people are used to working together so that the response time can be shorter.
Mm-hmm. You did mention that there's new funding from the CDC to extend it for 2 more years.
Right.
Is that going to be long enough to take us to the next, public health emergency, do you think?
I sure hope so. I think we all deserve a break from COVID for a year or two. But there are other issues that come up besides pandemic safety. There are other issues that come up besides pandemic vaccine safety with regard to vaccines. New studies come out that need to be replicated that require more diverse exposure or a larger denominator. So it's not that there's a lack of work, but we were fortunate because the COVID was very much in the public mind, and that allowed funding to become available. And I'm hoping that this doesn't turn to a lack of attention and lack of funding in the future.
Yeah. Okay, here's a question from Shaza for Steve. When encouraging participation from other countries, you mentioned encouraging the use of electronic health records. For many countries, there are other pushes to have electronic records to address specific goals or objectives. Is this the same, or just finding ways where the global network is leveraging existing pathways to build administrative databases within these countries?
Yeah, I think what I'm talking about is electronic health records is surveillance, because what to back up, if you look at what the Vaccine Safety Data Link has done and what the primary focus of what the GVDN is doing, we're relying heavily on hospital and emergency visits that have already been coded and are accessible. But as we all know, to be coded as hospitalization, you have to leave the hospital. Someone has to go through the records and code it, and then the data has to be made available. And that can cause a time delay of several months. Usually 6 months is sort of average from my understanding. And if you want to get beyond that, or to have things more readily accessible, you need to be looking more at raw data. The FDA has funded a BEST project, BEST, to begin to get that kind of experience, but it's just beginning. I think we really understand less about the variability in the data and the data quality. So it's a new effort that will require some work.
Yeah, I mean, I guess, there have been some countries where they've done it, like where they have, existing linkage of the vaccination data with electronic health records, like, in the UK or Israel, but it seems to be just relatively limited numbers of countries where they're able to do stuff in more real time.
Yeah, I just want one comment on that. I think, some outcomes lend themselves more to this than others, if they're very specific and very likely to be confirmed by testing that you can use in the record. Guillain-Barré comes to mind, but even with hospital records that are coded as Guillain-Barré, we know that up to half of them are something else. And I think for other outcomes, such as a seizure, for example, where you will see rule out seizure and ER diagnoses, or rule out this, rule out that those are very difficult or more difficult to untangle and lend themselves less to looking at raw data that isn't confirmed in some other way.
So here's a question for Julie from Manish. Having done multiple canvas rounds with different vaccines, is there any value in combining the control data to establish more standardized background rates? And has there been any changes over time in these rates that you've observed?
Yeah, that's a great question. Yeah, I think we'd have to look at that closely. I think probably for some of the symptoms, it might make sense, but a lot of the control, a lot of the sort of non-specific symptomatic symptoms that you can get following vaccination are also oftentimes harbinger of respiratory infections and other sort of infectious diseases that can circulate on a cyclical period. And we know that kind of varies over the course of a 12-month period. So, if we were going to do it, you'd almost want to be able to have the control data, ideally maybe over like 12 months, and then you could try to start mapping that background rate cyclically and then have that as more of a comparator. It's a good question. I'll have to give it some thought. We've got a lot of great data that we're probably not fully utilizing because, who has the time to kind of think through a lot of this, but I think that's a really good thought.
I guess in the past, this was built on the influenza platform, and you were getting people kind of around the same time that just hadn't received the vaccine yet. And I guess with COVID, it might be a little different because we've kind of decoupled it, the seasonality aspect somewhat. But
yeah, and it was quite, in terms of what was circulating during COVID, looked really different than what we've seen pre-COVID. So a question, how reliable, how representative would that control period be sort of 2021 moving forward, given, all the other kinds of public health measures that were in place that we know were affecting what else was circulating. So, yeah.
So here's a comment and question from Bob Chen. Canvas is probably a version of the cohort event monitoring, or CEM, a method developed by the UK NHS for post-marketing surveillance of new drugs. And two, here's a question. For unvaccinated experience, have you tried asking vaccinees for incident medical events, or even 30 days pre-vaccination, 7 or even 30 days pre-vaccination?
Yeah, so that's actually how we do it with our, that's how we do it with our influenza surveillance. So the way that has worked historically is our vaccinated group. So whoever was, let's say, the 2020 vaccinees, we would then contact them before influenza vaccines are available in Canada, and they would be our control group. And so we would get their week period before the vaccines are available on our previous vaccinated group. And so the advantages of that are your controls and your vaccinated group are quite similar, so you don't have, the concerns that if you get someone who's never ever been vaccinated, they're so different from someone who gets a vaccine. There may be all sorts of other stuff going on that you can't sort of control for in your analysis. So you've got, a really nice cohort to kind of look at that at. With COVID vaccines, we broadened it out. Obviously, we broadened it out a bit more. No one had a COVID vaccine, so it wasn't really easy for us to contact the previous year's COVID vaccinees. I mean, moving forward, if the monitoring continues around COVID vaccines, that's something that we could put in place. But I think the control group for our COVID vaccines, and one of the things we'll want to do kind of moving forward is, to the extent that we can, is how different do they look from our existing vaccinated group and how similar are they? So. And then I guess the other point I should make is we did have sort of a retrospective control survey that we ended up running for COVID, where we would capture kind of enroll somebody and get their 7 previous days and their previous 30 days events happening. And that was just, the way the vaccines rolled out, it was fairly challenging. Things were constantly changing, and we would sort of have one control group, and then all of a sudden they would be eligible for vaccine, and they'd be disappearing before we'd enrolled probably the number that we were hoping for. And so we were trying to be able to capture people before they were no longer able to participate as a control. So we've kind of done what you're suggesting there for both influenza and for COVID.
Great. Any other questions from anyone out in the audience? It's a relatively quiet audience today. So do you want to tell us a little bit about what you're doing for monkeypox, Julie? Or
well, I would say I was I don't know if relieved is the right word. I found it interesting, Steve, that you're running into issues around monkeypox surveillance, because we've definitely run into issues with monkeypox surveillance as well. We have set it up in place. It's in one of the provinces, and so we will be capturing safety data. Primarily, I would say at this point in the campaign on the dose 2s that are administered. And so it's a similar survey to what we've done for influenza and for what we've done for COVID, with slightly different questions, a bit more information around rash, a bit more information around, some of the underlying autoimmune diseases that may affect someone's response to the vaccine. But otherwise similar to what we've done with other things, and we have the survey set up to go after either dose 1 or dose 2, because certainly at the point in July when the vaccine program was rolling out, it wasn't clear at that stage whether it would be a 1 or 2 dose program. So we've got the flexibility built in for both. In terms of a control group, we're still working on that aspect of it, because it took such a long time to kind of get all of the approvals in place just to capture the vaccinated individuals information that the controls has been put on side. But the idea would be to, again, try to capture a similar group to the vaccinated group, but individuals who didn't take the vaccine.
Yeah, that's leads to the next question from Stephanie Meyer here, and she says, this may have been addressed, but what is the recruiting process for the unvaccinated control group? And I imagine it's different for the different vaccines, but
yeah, no, it's absolutely different for different vaccines. So as mentioned with influenza, when someone signs up to participate in the influenza survey at that time, we tell them we're going to email you again, 11 months from now, and you'll be a control. And so they sort of know upfront that they should be getting 2 surveys. For COVID, we did a separate recruitment process because, again, this was a new vaccine, nobody had received it, and we kind of opened up recruitment to everybody. So we did a lot of promotion in the media, social media. At some of our sites, we've got participant databases where we're able to individuals have said, yes, I'd like to be contacted about research. So we did, email blasts out to that group. We worked with different community groups to also kind of send out invitations, really kind of trying to cast as wide a net as possible to get people interested in participating. And it was really great, I would say, sort of that period in early 2021 where the vaccine was so restricted, and a lot of people were wanting to be involved, contribute somehow. And so we had actually a really fantastic response kind of in the early Q1, Q2 of 2021 for people who weren't yet eligible to get the vaccine, but really wanting to try to help out. Monkeypox, it would be similar to sort of what we did with COVID. So again, working with a lot of community partners to try to get the word out and encouraging people to enroll. And as well, if we've got participant contact databases, we would reach out through those as well.
Mm-hmm. And I just had a question for you related to that, and I just escaped my mind now.
Well, while you're thinking, Jeff, this is Steve, I have a question for Julie. Put her on the spot from two different directions. If you compare the Canvas program to VSafe in the US, where they used a telephone app, I mean, what do you see the strengths and differences there?
I don't know that I know enough about VSafe. So Steve, I may have you comment a bit more on that because I sort of tried to follow it early on, and I may not have all my information correct. So I'm a little hesitant to make direct sort of compare and contrast. But I think my understanding was it was mostly healthcare workers, and there's a lot of pluses to doing this type of surveillance in healthcare workers because they very much understand some of the medical terms that may be used. And I think in that sense, you can have really high quality data that comes in, but they are not necessarily reflective of the general population, which would be the downside of using a healthcare worker group. I think my sense is probably the automated telephone was potentially an easier route to go, although I'd need to have more of the details around how that worked. And I think the other question I would have is the level of detail they were able to get through that process, because I'm not sure, I don't know if they sort of sent out a full survey where they captured all of the, symptom information, medical diagnoses, that type of thing that you can get with an online survey. But yeah, and I think, the other advantage might be, one of the limitations I think of Canvas is that you do need an internet connection, and you need to be well versed enough in getting on the internet to be able to do it. And so I think that if you could move away from that, you would be able to reach some of our perhaps more vulnerable groups that don't have the ability to kind of interact with technology that way. So that I would see as a plus. And I think increasingly for Canvas, we're going to need to look at a more mobile way of, right now we sort of use email. And I think email is the older person's way of communicating, and not many young people actually use email very frequently. So I think if we want to really capture a younger population, we're going to, sort of teenagers and young adults, we probably need to be moving into more text messaging with maybe a link that they can then click on and respond to for that. We did look at that as Canvas COVID was rolling out, but just with everything else that we had going on, it was, you mentioned the challenge of trying to do this as things are happening, and that was just something that sort of fell by the wayside. But I think it's probably worth revisiting and figuring out how we could put that in place.
Okay, thanks.
Okay, now we've got 4 more questions that just came in. So one from Manish, a question for Steve. You mentioned briefly the complexities around identifying vaccine-associated enhanced disease, and this was a huge question at the start of the vaccine campaign. Can you speak to this and the challenges and where he sees the current status of this issue?
Well, the reason this came up as an issue is that it was observed in animal models for MERS, which is closely related to the SARS-CoV-2 virus. What the phenomenon is, and has been well described for an inactivated RSV vaccine, is that you vaccinate people and then their risk of serious disease is higher than if they weren't vaccinated. So people have looked at the high level of efficacy that has been seen with RNA vaccines, for example, and said, well, there's no evidence of this, but that's not really how you pick that up. So unlike many vaccine adverse events where you can develop a case definition and look for this in an individual, you can't really do that for vaccine mediated enhanced disease or VMED. What you need to look at is on a population basis, is there a subset of individuals who have more severe disease following vaccination than unvaccinated individuals? So that requires looking at ICU severity scores and also death rates, et cetera. So it becomes more of an epidemiologic issue to evaluate. Petri Hovi in Finland has sort of taken this on and put a tremendous amount of energy into this, and we'll see whether whether this is really being observed following any of the COVID vaccines or not. People said it would be more likely for inactivated vaccines, but it's also more likely after the virus has mutated and is less well covered by the vaccine and when immunity wanes. So we might not be seeing early on in the campaign of vaccination, but might be something that you'd see now, essentially after people's immunity is sort of waned. Many people are not getting booster doses, and we have a virus that's circulating that's quite different than what the vaccine they were vaccinated with.
Yeah, unfortunately, we are we've run out of time. So apologies to those whose questions we weren't able to get to, but I just want to thank Steve and Julie for speaking today, for Manish for co-hosting this with the CVPD. And we look forward to having future sessions similar to this in the future, joint sessions between CAIRE and CVPD. Thank you very much to the audience for attending today, and we'll see you later. Okay, take care. Bye, everybody.
Thank you. Bye.